This video will be the most comprehensive as well as educational video on the term spondylolisthesis. My name is Chet Donnelly. I'm a spine surgeon here in my hometown, Dallas, Texas. And over the next 20 or 30 minutes, I hope to educate you in terms of how we diagnose spondylolisthesis, how I use different technologies to treat spondylolisthesis, both non-operatively as well as operatively, as well as what are some different operations that could be done. Is it a laminectomy? Is it a fusion? What types of fusions? What's the typical recovery? And almost as importantly, when do you know you should have surgery? What are some of the things you should look for or should be thinking about when talking with your spine surgeon? Let's first talk about even what this term is, spondylolisthesis. Essentially, it's when one bone is sliding forward on the other bone. Now there's 5 or 6 different types depending on how you're counting. Almost all conditions can be broken up into 2 of the types. That's the degenerative type and the isthmic type, a big fancy word for essentially having a stress fracture in the back. I will go over the other types also. Let's first talk about the degenerative type. So the degenerative type, just as it sounds, is a wear and tear. It's a chronic aging, genetics, modifiable risk factors, things that lead to a worn out disc space, but as importantly, or more importantly, a wearing out of these joints in the back. So when these joints are worn out in the back, these are called the facet joints. They're what move the spine. Just like when you get arthritis on your hands, when you get a callus formation on your hands, you can get that on these joints. They don't lock into place as well, and they might start slipping forward because they don't lock in. That will drag the nerve, squeezes the nerve. That's what causes numbness and pain shooting down the body. So besides the degenerative type, the next also very common type is something called an isthmic type. Again, a big fancy word. Essentially, it's a stress fracture from hyperextension. It could happen all of a sudden, but usually it's a hyperextension injury over time. And this spiky part of the bone, just like if you can feel the spike on the back of your neck or spike on your lower back, has a fracture in the columns of it called the pars, P-A-R-S. So a pars fracture makes this bone wiggly. Well, that in itself is not too much of a problem, just having that. In fact, a lot of times they might heal on their own or they might be totally asymptomatic. But frequently, you lose that 360-degree tension band. What that results in is extra stress then going to the disc space as well as muscles in the back. Essentially, the joint is no longer connected. So you're not really getting any joint arthritis. The joint is no longer the issue. The bone is separated from this joint. All the stress goes through the disc space from the hyperextension over time issue. This disc space now starts to lose disc height. It starts to lose hydrogen. It starts to squeeze down, and just like those medieval guillotines that would come down and chop your head off, that kind of is what's happening to these nerves. It loses the height and it starts pinching the nerves. Additionally, because it doesn't have that stability of the joints in the back, it doesn't have the stability of that disc space, the bones start sliding forward on each other potentially, and that also starts squeezing it. The analogy would be like if you're crawling out of your window and then all of a sudden the wall started squeezing in on you and now also the window is coming down on you. This nerve coming out of the neural foramen, another big fancy word, but these neural foramen are where the nerves come out, that starts to get snug from the loss of disc height and the bone slipping forward. So the isthmic type is another very common type of these 6 types of spondylolisthesis. Another type of spondylolisthesis is called congenital. This means it happens in utero. It happens when you're still being developed for various different genetic and environmental reasons. Pars, that same thing that fractured in that other setting, and it just gets longer, and that leads to one bone being just naturally more in front of the other. Another type of spondylolisthesis is called pathologic. Pathologic could either be infection, maybe the infection eats away at that bone and causes it. It could be a tumor. The tumor, unfortunately, are usually in these posterior structures, these back structures. That could result in the instability. Another type of spondylolisthesis is called traumatic. This could be big car accident, falling off a ladder, things that just cause a rapid trauma to the body. You get an acute fracture to this area, and that shear force, the flexion distraction nature of it, could lead to the bones shifting on each other, and that's in a traumatic spondylolisthesis. And the other type of spondylolisthesis is called iatrogenic. Essentially, that's when maybe too much bone is taken, and that results in instability of the spine. Okay, the next thing I want to go over is the classification system, or the grading system of spondylolisthesis. There's several of them out there. The most common one people are referencing, the most common one patients reference and even radiologists reference, is the Myerding classification. The Myerding classification essentially breaks the top part of the vertebral body into 4 different quadrants. So if you have no slip, you're a grade 0. Well, once it slips somewhere between the 1% up to the 25%, that's considered grade 1. That's the most common type. If it goes beyond 25% and goes to the midway point, so 25% to 50%, that would be grade 2. If it goes to the 50% to 75%, that would be grade 3. If it goes from 75% to 100%, that's grade 4. There's a grade 5, also known as spondyloptosis. That's essentially where the bone dislocates. And that's more common in a congenital setting. Maybe someone's born with it or they're born with a high grade. So it sometimes is more common in the adolescent time period is when it starts to get diagnosed and treated, is essentially when this bone is so displaced, it's essentially shifting off. I don't want to do it on this spine model here because one day this flimsy string is going to break in there and then I have to get a new spine model. But that would be spondyloptosis, which is a very high degree of spondylolisthesis. Let's spend a little time talking about the treatment and the diagnosis. First, the diagnosis and what technology I use to diagnose these. Now again, I just mentioned 6 different types, so some of these kind of vary from type to type. For the purpose of this video, I'm particularly going to be focusing on the most common types, the degenerative type and the isthmic type. That's the stress fracture one. Usually seen maybe in someone in high school as repetitive hyperextension, gymnasts, football players, swimmers, tennis players. Also some people who just work out a lot, and then other people just have a genetic predisposition and just get it, and they never played any of those sports in high school. But those are some people that are more likely to get the isthmic hyperextension injury over time type of spondylolisthesis. So what are some of the technologies I use to diagnose it? Well, x-rays are critical, and these are x-rays where I want the patient standing up. Essentially, I want to see what gravity does to the spine. I don't want to see them when they're laying down. I want to see what gravity does to the L4, the L5, the S1. I want to see where their hips are in relation to their spine. You want to get, at minimum, a front view, a side view, a leaning forward view, and a leaning back view. Getting an oblique view, so instead of just being sideways, a little oblique, is a little debated in terms of the clinical utility of those. It definitely has some merit in some, but it's not a critical thing to get. In addition to x-rays, essentially every time a spine surgeon is also going to want and is going to need an MRI of the spine. Now the MRI is different because the MRI shows the nerves, it shows the spinal structures such as the thecal sac, the spinal cord. It shows how much tightness from either thickened tissue or from instability of the bones is being squeezed on that nerve. So an MRI is critical to the diagnosis as well. Additionally, not imperative, but in certain cases, the spine surgeon might order a CT scan. And a CT scan would also show that fracture. It could also show the arthritis of the joint. It could also show some of the underlying pathology I mentioned earlier in the video, but it's not always critically needed. If a patient can't have an MRI, maybe they have severe claustrophobia, maybe they have a pacemaker or some other metal implant that is not MRI compatible, a CT myelogram is another advanced technology I use. It's somewhat uncomfortable. Pretty much they put a needle into the back, you put dye around the spine, around the thecal sac, around the neural elements, and then you get the CT scan, and that's called a CT myelogram. There's also a very narrow subset of patients. I might order something called a SPEC CT. That might be useful in the early diagnosis of a pars fracture. There's also the pathologic variant I talked about earlier, and a SPEC CT sometimes is used in that setting. Okay, so in addition to the diagnosis of it from various radiographic techniques, let's talk a little bit about the management. Now, the first thing you might be thinking is, Do I even need to have this treated? And the simple answer is not necessarily. Look, again, there's 6 different types. So if there's a tumor or an infection type, well, of course, that needs to be managed, that needs to be evaluated. But in the overwhelming majority of the cases, which are the degenerative type, which are the hyper stress reaction, the hyperextension type, the isthmic type, not necessarily. If you're doing great, if your back just hurts you every now and then, if you can still enjoy life, if you can still coach your kids' games, if you can still build forts with them, if you can still go hunting, scuba diving, you name it, well, of course you don't need to have surgery or even treatment for just having that underlying diagnosis of degenerative or isthmic type. If it does start to interfere with your activities of daily living, I always start them on a conservative, non-operative role. Now, there are exceptions to when you want to maybe go ahead into surgery first, but that's definitely not the norm. And the overwhelming of my patients not only start with conservative therapy, but that's all they need for a very good while, if not forever. Let's talk about what that conservative option is. Okay, so in terms of conservative option, there's going to be a whole list of things. Some patients do part of these, some patients do none of these, some patients do all of these. I always start my patients on a formal course of physical therapy. That's going to the gym with a trainer, going to the gym with this trained physical therapist expert 2 times a week for 6 weeks. They help strengthen the core muscles, abs, your quadriceps, your hamstrings. They show you different activities you can be doing at home, different stretching modalities, really working on your hamstrings. I know I keep circling back to that, but that's just a big part of spine pathologies that us as spine surgeons have gotten a lot better understanding of, and that's how the hamstrings are involved in all of this. In addition to physical therapy, I'm also okay with involving other specialists, such as a chiropractic provider. The chiropractic providers, I don't want them popping your back or doing all these crazy things that you see on TikTok videos. That essentially has no role in medicine, but deep pressure on the muscles, stretching, maybe very mild lumbar spine manipulation and stretching is okay. I'm okay with acupuncture, I'm okay with cupping, I'm okay with aquatic therapy. Why not, right? Those things are all been somewhat shown to help with the non-operative modalities in terms of lumbar spine pathologies. Other things that my patients, as well as peer-reviewed studies, have shown to be helpful: TENS units, electrodes on the back bracing from time to time, ice and heat therapy, of course. I'm not going to go into certain specifics of medications in terms of dosages, but there's definitely a role for certain medications to help the back pain and shooting down pain. Some of these medications could be a Medrol steroid dose pack. That's either a 5 or a 6-day course of oral steroids a patient takes. That's been shown to be extremely helpful in mitigating the acute pain a patient might be having. Anti-inflammatories such as NSAIDs, non-steroidal anti-inflammatory drugs, are very, very helpful in helping decrease the inflammation either around the joints or around the nerves or around the disc space. Gabapentin, Lyrica, pregabalin, those are all somewhat kind of the same medication in a way that helps with some of the neuromodulation of those nerves. Muscle relaxers from time to time. Again, you might be thinking at home, goodness, I'm taking all those medications and I'm still doing terrible. Well, that's when surgery might have a role, and we'll get to that in a minute. And the other thing I haven't talked about a lot is, as the spine surgeon, I love being the quarterback of my patient's care, and I very frequently will direct them to one of my pain management colleagues. And if I don't know one in their hometown, I honestly look for one in their hometown or ask one of my friends who might be practicing in their hometown about a pain management doctor. Now, what do those pain management doctors do? I'm not talking about spinal cord stimulators or pain pumps or any of that stuff. What I'm specifically talking about are different injections. Steroid injections, lidocaine injections, marcaine injections, different injections to help calm down the irritation, calm down the inflammation. Essentially what these are is they can either do the injection in the joint, such as like a facet joint injection. That's something that would likely be helpful for some axial back pain, some back pain that's kind of over the belt area. I would not anticipate that'd be very helpful for shooting down numbness and tingling. That would be something where you'd want to move that needle a little more to the side and a little deeper. Something called a transforaminal epidural steroid injection, which we abbreviate as a TFESI. That's pretty much doing an injection around the nerve root. Because if you think about it, we talk about that pars fracture type where the joint is not even connected. Maybe I have a patient who's reaching out to me from across the world and they're like, well, I've had these injections in my facet joints and they haven't helped. And I say, well, of course they haven't helped because your facet is floating in the wind. It's totally separated from the rest of the spine, so a facet injection would not be indicated in that case. You're better off with a TFESI or something else. But there's definitely a role for steroid injections in treating both back pain as well as numbness and tingling, something called radiculopathy, pinched nerves. Many high-impact studies in peer-reviewed journals support this. There's no debate that those are effective. Okay, let's take a little time out here to talk about who needs surgery for spondylolisthesis. The first category of patients would be those that are having severe muscle weakness. Those would be the patients that maybe can't raise their foot off the ground, raise their big toe off the ground, or their quadricep, their thigh muscle, is buckling on them and they're falling to the ground. If you fall to the ground, you can hit your head, break your wrist, break your hip. Those are all pretty big deals in terms of needing additional care or additional surgeries. So if you have a muscle weakness, that might indicate you to not have non-operative care and kind of go straight to the surgical options. Another person that would benefit from surgery is when you can't do your activities of daily living. Let's talk about what those are. So activities of daily living are as simple as it sounds. It's things you do every day. Maybe that's do the dishes, do the laundry, walk upstairs, coach your kid's soccer game, swim in a pool, go golfing, whatever it is. If you do the non-operative care and the non-operative care doesn't work and you're not getting better from the non-operative care and you still can't do those activities of daily living, of course, then you'd be indicated for spine surgery. And again, that's either laminectomy, non-fusions, that's either fusions through the belly, through the side, through the back. So many different options in terms of how to fix your underlying issue. In terms of what surgery do you need for spondylolisthesis, well, let's talk about it. Again, there's 6 different types, and so if you have the tumor type, well, that's obviously a way different tumor. But again, talking mostly about the degenerative type and the isthmic type, which is what most people have when they have spondylolisthesis, there's 2 different types of surgeries in a nutshell. Essentially, there's a non-fusion surgery and there's a fusion surgery. Not every patient is a candidate for either one of these. It somewhat varies on many factors, and it's hard to put a one sum of it all into a video. But essentially, let me go over the different types of surgeries and why a surgeon might pick one over the other, and then I'll kind of tell you how I think about it in terms of the patients I'm looking at. Okay, so in terms of the non-fusion surgeries, a surgery that's very common in the setting of spondylolisthesis might be something called a laminectomy. This is a model from Demo Spine that shows it really well. So if this is the front part of the spine, side part of the spine, back part of the spine, let me show you what a laminectomy is. The immediate advantage of the laminectomy is that there's no rods or screws, there's no fusion, and that's very attractive to most patients, but it's not a great option in many cases. Essentially what the laminectomy is going in here, removing part of the spinous process to get into the thecal sac or the spinal cord, depending on where you're at in the spine, and cleaning out the pinched nerves, cleaning out the arthritis. So in the degenerative type, a laminectomy is definitely an option. Now, if you have unstable spondylolisthesis, that's where the bone is actively moving a certain distance from flexion to extension, or when you lay down versus when you stand up, so comparing the MRI even to the X-ray, it's definitely a source of controversy in spine surgery whether an unstable should just get a laminectomy. A laminectomy and unstable might result in worse outcomes and an eventual need for surgery in the future, which would be the fusion surgery. I usually tell patients the analogy of this section of bone that's being very surgically, meticulously removed is almost like if you're in your office and you look up and you have those ugly tiles on your ceiling like most of our offices do. It's like taking a strip of those tiles out. You still have the stuff on the left side and the right side. You still have the column of support bone that's above you, but you got to get into the spine somehow. It's extremely safe, extremely effective, and most spine surgeons' favorite thing to do because patients just bounce back so fast and it's a very low morbidity and patients just return to their activities of daily living quickly. The fusion option is the other option. Now in terms of fusion, this is where it gets crazy confusing because there's just so many types of fusions. Essentially, for the purpose of this video, when I say fusion, here's what I mean. At the minimum, rods and screws going through the pedicles, kind of like this, into the bone. Okay, so in addition to the rods and screws that go into the vertebral bodies, in the disc space, you should have a cage that's in there. Now I say should have because in modern spine surgery, that's what most spine surgeries have because there's huge advantages, but there's definitely certain cohorts of patients that are not good candidates, or there's certain type of medical comorbidities, or maybe you just don't want to spend the extra time to put that spacer in there. Let me tell you what some of the advantages are of having a spacer in the disc space. And again, when I say spacer, I mean a cage. I mean a titanium or cadaver bone or a medical grade plastic thing called PEEK that goes into this space. Essentially, the spacers do three things. They, one, restore disc height. So just like earlier when I told you that these medieval guillotines were coming down and squeezing the nerves, these spacers go in here and take the pressure off the nerves. Sounds great. Two, they help improve fusion rates. Instead of just relying on the screws and sometimes the bone graft that's on the back part of the spine, which I haven't talked a lot about yet, you also get fusion through this disc space, and you can put synthetic bone, you can put the patient's own bone, you can use the properties of that spacer to grow bone through this disc space, so it's another site of fusion. And then as importantly as those other things, getting a spacer in there allows the spine surgeon to hopefully prevent additional surgeries. That's right, by doing a spacer, you get more curvature in the spine. The spacers are usually bigger in the front, skinnier in the back. Let me show you what I mean by that. So if this is the side view of the spine, if the cage is fatter in the front, so on this side, skinnier in the back, it helps curve the spine back. It helps restore lordosis. Lordosis is another big fancy medical word that means curvature backwards of the spine. Lordosis is good in the neck as well as in the lumbar spine. So when we put a spacer in there, you can imagine it helps curve the spine back. So cages are good in the setting of spinal fusion. Again, there's certain regions of the country or surgeons or patient comorbidities where you might not get a cage. That's a little surgeon specific, but in general, cages are good. In terms of how that cage gets in there, that's a really big part of the surgery, right? For the purpose of this video, for the purpose of degenerative and isthmic, I'm going to break into three categories in terms of how to get that cage in there. You can go through the belly, so a small incision under the belly button, you get that spacer in there. In some patients, you can go above the hip, the iliac crest, under the ribs, and that's called a lateral surgery. That's a great way to do it. Or you can put the cage in from the back. Now, one point of clarification is those screws are always going in from the back. So you might at home be thinking, well, if the screws are going in from the back, shouldn't I just have it all from the back? That sounds like a better way to do it. Maybe, maybe not. There's so many factors to go over. Okay, now that I've established that there's three ways you get the cage in, there's three different styles of cages in a way from talking about these. You get a cage that goes through the belly, and those are these big A-lift cages. The cages that go in from the side are longer. These are lateral cages, so belly cage, lateral cage. And the cages that go from the back are a little smaller. These are the T-lift or the pliff cages right here. At home, you might be wondering, is bigger better? Are there advantages, disadvantages of the cage? Man, it is the longest answer in the world, but essentially, bigger is better, more surface area is better, there's less subsidence, there's more height restoration, there's more maintenance of that height restoration you get from day one, and you could also get in more lordosis, more of that curvature of the spine. So why would your surgeon choose one over the other? Again, so many factors. Let me try to break some of them down for you. The first factor is which level of your spine needs the fusion. If it's at L5-S1, in almost all patients, the crest is too high, and so it's very difficult to get in from a lateral approach. Similarly, at 4-5, the crest might be too high, or the muscle you have to go through, called the psoas muscle, in some patients is just a little more forward, and so the nerves, or not these nerves, but the nerves in the psoas are a little more posterior, and so it's just not the safest approach in that specific patient. Other people, you can go through the front, such as at 4-5, at 5-1. The problem with the front is that you need a surgeon. And if you're wondering at home, is that a problem? Is that a good thing? Is that a bad thing? Anytime you have to schedule with someone else besides your own doctor, that's a little problematic because you need to be on someone else's schedule as well. Well, that's also a determining factor. Going through the belly in terms of having a vascular surgeon or an access surgeon available. Different regions of the country, that's no problem at all. For instance, here in Dallas, I don't even know how many approach surgeons we have. Probably 10 to 12 just in this DFW area. And essentially all they do is they drive around from different hospitals. When you book with them specifically, they make a small incision about the size of a credit card, maybe smaller, under the belly button. They dissect that area, they move the blood vessels aside, and then the spine surgeon cleans out that area. There's huge advantages with an ALIF cage and an ALIF procedure. I'm biased though. I'm very fortunate that I live in an area where I legitimately know and think we have some of the best vascular surgeons in the nation. Some vascular surgeons don't like going above L4-5. If it's a lateral surgery, many spine surgeons love doing L2, L3, L3, L4 for a lateral surgery. L4-5 depends on somewhat the anatomy of the psoas. Is that psoas muscle a little forward and the nerves are in the back? Well, then you might not want to do a lateral surgery at L4, L5. So there's several factors in terms of the level, where the hip crest is, the patient's weight. Do they carry a lot of weight in the front of the spine, in the side of the spine, or in the back of the spine? Those are all definitely many factors that a spine surgeon considers in terms of how to get that spacer, how to get that fusion device inside the disc space. Once we've established that the spacer goes in this disc space between the two vertebral bodies, you still need to have these screws in the back for the posterior spinal instrumentation. The reason I keep showing this spine model and holding this spine model here is because this shows you exactly how I use technology to get these screws in. The reason there's these towers here, these rods here, is because they're actually not that tall forever. So this is usually where your skin is, and then underneath you have some fat layer, some muscle layer, and then the bones. So when I'm doing my surgeries, after that cage goes in, I do a spin with a CT machine or something similar to a CT machine, and then I'm either using a robotic navigation, something called freehand navigation, or a really, really fancy thing I use a lot is something called augmented reality navigation. This is augmented reality. It's a headset where I'm able to see under the patient's skin, under their muscle, under the tissue, and through 3D navigation, I'm able to see all their anatomy, and it's one of the many technologies I use to treat spondylolisthesis of the spine. I can therefore make a small incision. Through that small incision, I can place these screws down, and then the rod goes there after I test the screws, and then we break off these towers right here with a fancy tool that goes down. I break off the towers, and then you're left with these pedicle screws under all the skin, under all the fat, under all the muscle are these pedicle screws. So these towers here kind of show you how I use technology to put them down, put them down. I put the rod that connects them, and that's the posterior spinal instrumented fusion that spine surgeons use to connect those two things. Let's talk a little bit about the recovery after spine surgery. Now again, these spine surgeries differ. I have a laminectomy surgery, we have a fusion surgery. The fusion surgery has variability also. Are we going through the belly, going through the side, how many levels, what's the patient's status coming in? So there's so many different factors that really go into it that could very change it. I have a video right here on the post-operative recovery of a laminectomy. I would encourage you to click that to learn that one. And then I have another video right here. That's the recovery after a spinal fusion. Again, it varies whether you're a 75-year-old female or a 30-year-old male in terms of what your recovery would be. But in general, in the first 6 weeks after a spine surgery with me, I want you up and walking that day. I might discharge you that day or 1 to 3 days later if it's a spine fusion. A laminectomy, maybe home that day, maybe home the next day. Spine fusion, home 1 to 3 days later. On both surgeries, up and walking that day though, that's a big deal for me. Okay, so to summarize, spondylolisthesis is obviously a topic that you can tell I'm passionate about. I'm passionate about the research on this topic, I'm passionate about the diagnosis, and I'm passionate about the treatment. One of the reasons I like this topic so much is because, frankly, it's pretty straightforward for me to diagnose it and fix it because I have great resources. And a lot of that is based on the area I live. Fortunately, I go to a bunch of different hospitals that have put in that investment capital on these machines that help me do it. What do I mean by that? Well, some of these CT machines are about $1 million. These robotic navigation are about $1 million. The augmented reality headsets, about $500,000. my goodness, I'm very fortunate that I have these hospitals that they put that capital into their technology so that the surgeons can use it. The reason I fight for that is because it leads to smaller incisions. I don't need to see the whole spine. I have technology to even see through the skin, right? So smaller incisions lead to faster mobilization, less risk of blood clot in the leg, blood clot in the lung, pneumonia, urinary tract infection. Those are all the things I'm thinking about, and that's why I like doing minimally invasive surgeries. The other benefit of the area I live in, I have some great vascular and great approach surgeons. They drive around in different hospitals, and they legitimately are some of the best in the nation at making that small incision and going through the belly and using some of that high impact technology to restore the disc height, to restore the lordosis. So I'm very fortunate to have both of those resources readily available. I encourage you to get with your spine surgeon if you're having the conditions of spondylolisthesis and the associated symptoms, and let your spine surgeon be the quarterback for your care so that they can best and most efficiently diagnose your issue, as well as help you in the non-operative as well as the operative strategies to cure your spondylolisthesis.